Welcome dear students, I am Dr. Pratyusha and in this video let us continue learning about otosclerosis. We have already learnt about what is otosclerosis, its etiology and pathophysiology. Let us continue learning from the clinical features. So we shall see the clinical features and management of otosclerosis in this video. Clinical features, the first and foremost important clinical feature would be hearing loss. And whenever I say hearing loss, it should always be specified as to what type of hearing loss it is. And that depends upon the area of otosclerosis involvement. If the foot plate of stapes is involved, it becomes conductive type of hearing loss. And if at all the cochlea is involved, it happens to be sensory neural type of hearing loss. And if at all both are involved, it could be mixed type of hearing loss. So the type of hearing loss depends upon the area of involvement, but as we know that the stapedial otosclerosis is the most common variety, so conductive type of hearing loss would also be the most common presentation. Conductive hearing loss. But you must remember that sensory neural type of hearing loss is also possible, as well as mixed type of hearing loss can also occur. This is about the hearing loss. The next feature is about the patient's own voice. How does the patient speak? It is low-toned and monotonous. The patient speaks in a low-toned, monotonous fashion. Because bone conduction is better than air conduction and the patient happens to hear his or her own voice louder and better. The next feature is something called as paracusis willisii. What is paracusis willisii? Normally, for anybody, when the surroundings are noisy, our hearing becomes dampened. But in these people, they hear better in noisy surroundings than in quiet places. How is that possible? It's a very simple logic, because when the surroundings are noisy, anybody will tend to speak in a louder volume. And this louder volume helps to compensate their conductive type of hearing loss. So the patient happens to hear better in noisy surroundings, and that is called as paracusis willisii. This is generally told as a distinguished symptom of otosclerosis, but please understand that it is also possible in any type of conductive hearing loss, because the logic remains the same. Whenever there is noise, people will speak in a louder volume and patients of conductive hearing loss will happen to hear better. That is paracusis willisii. Hearing better in noisy surroundings. But for all practical purposes in the examination, if you find the term paracusis willisii, otosclerosis has to come into your mind. Next clinical feature is tinnitus. What is tinnitus? It is a ringing sensation of sound felt by the patient. And patients of otosclerosis usually complain of tinnitus, and this is more in cochlear type of otosclerosis and more so when the disease is active. Next comes vertigo. Vertigo is not a very common clinical feature that is seen in patients of otosclerosis, but still it is important because in patients suffering from vertigo with otosclerosis, the management is slightly different. Okay, because while performing stapedectomy, we have to make sure the patient does not have vertigo, as stapedectomy can worsen the vertigo. Okay, and we have another interesting term, that is Bezold's triad. You must have heard about Bezold's abscess. This is Bezold's triad. And what does the triad constitute of? It constitutes absolute negative RINI. That is, at all frequencies RINI is negative. Raised lower tone limit. The lowermost frequencies that we can hear are raised. Prolonged bone conduction. Bone conduction is longer than normal. These three features constitute Bezold's triad. And with this, the symptoms of otosclerosis are done. Now let us look into the signs of this disease. In our examination, what do we observe? Let us see from the beginning. What can we observe? Well, if we do an otoscopy, we can see up to the tympanic membrane. So the external auditory canal is normal. Tympanic membrane is also normal. Its mobility is normal, appearance is normal, everything is good. But as we know that the tympanic membrane is a semi-transparent structure, it reflects the changes that are present inside the middle ear also. So what happens is, when the disease is in the active stage, a reddish hue is seen on the tympanic membrane, which is actually coming from inside. A congested area is seen on the promontory, that is seen on the tympanic membrane as a reddish hue, and this is called as Schwartze sign. That is our first and most important sign. It is Schwartze sign. What exactly is Schwartze sign? It is the reddish hue that is seen on the tympanic membrane when it is seen in the active stage of the disease. This is one sign that we observe, and then we proceed after the examination. We proceed on to do the tuning fork tests. And let us see what the tuning fork test results are like. First, we do RINI. Now, I told you it is conductive type of hearing loss that is most often seen. So, when there is conductive type of hearing loss, what will be the result of RINI's test? RINI's test says bone conduction is better than air conduction if there is conductive type of hearing loss. So, RINI is negative. That is, bone conduction is better than air conduction. In a normal person, RINI is positive. Air conduction is better than bone conduction. Next, Weber's test. Because this is conductive type, it is lateralized to the worse ear. Lateralized to the diseased side. Next is absolute bone conduction test. Absolute bone conduction test compares the bone conduction of the examiner with the bone conduction of the patient. We are occluding the external auditory canal in this test and checking only for bone conduction. And here there is no problem with bone conduction. So, they both are equally same in the examiner as well as the patient. So, absolute bone conduction test is normal. Then we have Jelly's test. Jelly's test is negative. This is one of the very important features of otosclerosis. Jelly's test is negative. When is that negative? When the stapes foot plate is fixed. When the foot plate is fixed, whatever pressure changes you create in the external auditory canal, they are not transmitted inside because the foot plate is fixed. And so, Jelly's test is negative. These are the signs that we observe in otosclerosis. Now, let us move on to the management part of this disease. First comes diagnosis. The first test, the basic test that we perform in any patient of hearing loss is our pure tone audiometry. And in pure tone audiometry, what do we see? Conductive type of hearing loss. Conductive hearing loss is seen. And sometimes sensory neural hearing loss is also possible, and that time we see a mixed graph, a mixed pattern. And how do we identify mixed type of hearing loss on an audiometry? By seeing air-bone gap with both air conduction and bone conduction affected. If only air-bone gap is seen, it shows conductive type of hearing loss. If both the graphs are parallel to each other but are at a lower level, it shows bone conduction deficit. If both are at a lower level with some gap, it shows mixed pattern. There is another special feature that you observe in audiometry, and that is called as Carhart's notch. What is this Carhart's notch? Normally bone conduction is normal, but if at all if it is affected, at 2000 Hz frequency, you will see a dip in the audiometry graph. At 250 Hz, there is some hearing loss. At 500, it further increases. At 1000, it further increases. And it is maximum at 2000 Hz. And then at 4000 Hz, again, the hearing improves. So, this is how the graph would look like approximately. And this dip is called as Carhart's notch. And why does this Carhart's notch occur at 2000 Hz frequency? Because if you remember, each of the conductive apparatus has its own natural resonance, and the natural resonance of the ossicular chain is somewhere between 500 to 2000 Hz, and the stapes footplate, when affected, will show maximum changes at 2000 Hz frequency, which is observed as a dip, and that is called as Carhart's notch. Okay? And because of this mixed pattern, the type of chart that we obtain is called as a cookie bite pattern. Cookie bite type of audiogram is observed. These are the changes seen in pure tone audiometry. And the next test that we perform after pure tone audiometry is impedance audiometry. Impedance audiometry. In impedance audiometry, what are we measuring? The compliance of the tympano-ossicular system. And when stapes footplate is fixed, what will happen to the compliance? Compliance decreases. There is low compliance, and how do we see that in the graph? It is an AS type of graph that is observed, lower in compliance than the normal A type graph. It is AS type of graph. Next, we can perform a CT scan. What will you observe in the CT scan of the temporal bone? There is loss of the margins. Wherever otosclerosis occurs, the margins are lost. Initially, there is narrowing, and finally, complete obliteration of the oval window will be seen on the CT scan. What will you see? Loss of margins initially. Followed by complete obliteration of oval window. And in case it is cochlear type of otosclerosis, you can see something called as double ring effect. Double ring effect. Because inside the thickened capsule there is otospongiosis. So they are seen as two rings. These are the three investigations that we do: pure tone audiometry, impedance audiometry, and finally a CT scan of temporal bone. And we have made a provisional diagnosis of otosclerosis. But there are some differentials to be considered. And they are other causes of conductive type of hearing loss. Because in our investigations, what we mainly observe are features of conductive hearing loss, and there are other reasons possible for conductive hearing loss. So what are the differentials based on this? One is, it could be a normal serous otitis media. It could be adhesive type of otitis media. Tympanosclerosis. We are also observing features of stapes fixation, but instead of stapes, it is possible that the head of malleus itself is fixed in the attic. So, attic fixation of head of malleus. That will also show low compliance in impedance audiometry. And finally, congenital fixation of ossicles is also possible. Not because of otosclerosis, but congenitally only the ossicles could be fixed. Congenital fixation of ossicles. And ossicular discontinuity behind the intact tympanic membrane is also possible, but ossicular discontinuity would show an AD type of graph in impedance audiometry. It shows higher compliance. So it's a less possible differential diagnosis, but that's also possible. Keep it in your mind, ossicular discontinuity. After learning the differential diagnosis also, let us finally move on to the treatment part of otosclerosis. So first, medical treatment and then surgical treatment. Now, unfortunately, this disease has no medical treatment. No drug that you give can reverse this entire process of otospongiosis. But sodium fluoride has been tried. What will sodium fluoride do is, in the active stage of disease, it will try to stop that process there and it will cause maturity of the lesion. It will convert it into an active lesion so that further damage is prevented. That is done by sodium fluoride. So that is the only hope that we have. Sodium fluoride also does not cure the disease. Please remember, it can only halt the progress of the disease. And the final treatment is surgical. What do we do? Stapedectomy. Stapedectomy is the final treatment, that is removal of stapes. That entire diseased area is removed and a prosthetic is implanted there. That is stapedectomy. It is the final solution for otosclerosis. Earlier, stapes mobilization was done because initially we believed that stapes got fixed due to some reason, and if we make it mobile, everything will be fine. So we used to do a surgery and make the stapes mobile. But because we are not addressing the disease problem, what happened later on was, even after we mobilized the stapes, it would be fine for a period of time and again it would get fixed. Why? Because we are not addressing otosclerosis. So stapes mobilization was earlier done, but now it is not done anymore. And even fenestration surgeries were done, such as closing the oval window and making an alternative channel in the semicircular canal. But that is also not the right procedure, because in this process a postoperative mastoid cavity is created, plus there is an inherent hearing loss of 25 decibels. Now the maximum hearing potential will never be reached, and this 25 decibels hearing loss will always be there. And apart from these two, there is another solution that can be offered to the patient, and that is use of hearing aids. In people who are not compatible for surgery, hearing aids are a good option and the results are quite satisfying. So this is the treatment of otosclerosis. Thank you very much.